Every 2 weeks, folks. Thank you for showing up, because we do this because we're powered by you. People power research. The only reason that we're here today is because we have a mission, and we have each one of you on our mission with us. So please, whatever we ask, we're only asking because we want to see you be whole and complete. So we're going to be talking to you more about our speech project. So be very open to it. And one person makes a huge difference. Never think you're small. You're all beautiful and eternal. So
welcome to Everything ALS events, everybody, where we bring the experts to your living room. So June has been our brain-computer interface month, and we're super excited tonight because we have the BrainGate principal investigators from Mass General Hospital here to give you a detailed overview of their clinical trial. So thanks so much for joining us. My name is Lisa Deegan, and my connection here is I lost my younger brother, John, to ALS, and I'm a co-founder of Everything ALS, and we provide everybody with educational webinars, and we conduct digital biomarker studies, and we believe technology is going to be a key enabler to helping us with the mystery of neurodegenerative diseases. So please consider signing up for our speech study. You could read more about it at everythingals.org/research.
You should enter the speech study. It's very easy. We've tried to recruit some friends of ours to get involved in it. Takes about 20 minutes a week. Just answer the questions, follow the protocol. You learn about bamboo. I've learned more about bamboo than I thought I would ever know. So yeah, if you're not in the speech study, go to everythingals.org and hit the research button.
Today we have Dr. Leigh Hochberg. He is a professor of engineering at School of Engineering and Carney Institute for Brain Science and Brown University. He's a director at VA R&D Center for Neuro Restoration and Neurotechnology at Providence VAMC. He's also a neurologist at Mass General Hospital, and he also directs the Center for Neurotechnology and Neurorecovery at Mass Gen. Dr. Hochberg is the IDE sponsor investigator and principal investigator of the BrainGate Clinical Trial. His research focuses on the development and testing of novel neurotechnologies to help people with paralysis and other neurological disorders. So his research, along with the BrainGate team, has been honored with several prizes and awards, and also the research has been published in several medical journals, which is super cool. So we also have Dr. Daniel Ruben. He's a neurologist at Mass General Hospital and one of the investigators on the BrainGate clinical trial. He has a scientific background in computational neuroscience and has completed his clinical training in neurology and neurocritical care at Mass General Hospital and Brigham Women's Hospital in Boston. So now please join me in welcoming Dr. Leigh Hochberg. Floor is yours.
Thank you very much for that kind introduction, and thank you to everybody at Everything ALS for the opportunity to join you today. Let me get the slides up and running, and it is my real privilege to be able to tell you a bit about our ongoing BrainGate research. I'm going to take just a moment to hide one of these little floating windows that sometimes gets in the way. And I hope that over the next roughly half hour, 40 minutes or so, I'll be able to give you a brief introduction to what has been a 17-year now ongoing pilot clinical trial of the investigational BrainGate neural interface system, and then to be able to answer, I hope, all of your questions at the conclusion. I don't have any personal financial disclosures, I guess much to my dismay, but I do want to thank the Institutes of the National Institutes of Health, the Department of Veterans Affairs, and several of the philanthropies, each of which has really been instrumental to continuing this now fully academically based research. The most important disclosure by far, though, are the great group of people who I get to work with every day across a number of institutions and a number of disciplines. And some of them are listed there on the screen. But one thing that particularly when an academic puts up a slide like this, if you don't know this trick already, you should always ignore the people whose faces you see, because it's actually always the people on the right side of the screen whose letters are for some reason in a smaller font, whose names are in a smaller font, who have actually done all of the work that I'll be presenting to you, and who really deserve the credit. So I spend some of my time, as does my good friend and colleague Dan Ruben, who's on the call with us today, as a neurointensivist. So I work in a neurointensive care unit, helping people with acute, often life-threatening injuries or illnesses of the nervous system, and also providing care to people with progressive neurologic illnesses. And when I see somebody in the intensive care unit who I think might be able to benefit from a brain-computer interface or from an intercortical brain-computer interface in particular, which I'll describe in a moment, it brings me immediately back to the lab and reminds me what some very simple goals should be, not just for our research team, but I think really our goals for the field. And for somebody who has ALS, I want to be able to assure that person that they will never lose the ability to communicate. I'll get into a little bit more detail about exactly what I mean by that as we go through the slides, but that very straightforward goal is one that I feel deeply and motivates me and the rest of the team. Also, when I am in the intensive care unit, I will occasionally, as will Dan, occasionally meet somebody who has just had a brainstem stroke, who yesterday was able to walk, was able to speak, but suddenly cannot do so and may have become locked in, the LIS there representing locked in syndrome. And similarly, I want to be able to tell that person that they will be able to communicate easily again tomorrow. And I'll qualify easily, and I'll qualify tomorrow, and I'll qualify communicate. I'll be more specific about those in just a moment. And the types of technologies that I'll be describing today, I think will not only be helpful for people with ALS and brainstem stroke, but people with other neurologic injuries or disorders, including people with spinal cord injury or other types of stroke, to whom I'd really like to be able to say very plainly, I'm sorry that this happened, but you'll be able to move again tomorrow. None of those are goals that are yet achieved, but I do think that these technologies are on the way to achieving each of them. And now I'll be able to tell you a little bit more about why. So this is, as I've heard, this is Brain-Computer Interface Month for Everything ALS, which is great. And this one slide, which will be one of the more sciencey slides, if that's actually an adjective, that I'll show, is meant to describe just overall what is a brain-computer interface or a neural interface system. And regardless of whether it's the one that I'm going to describe to you today or one that you heard about a couple weeks ago or maybe next week, all BCIs basically have the same three components, which is a neural sensor, a decoder, and an assistive technology. So we begin with somebody who may be losing or has lost the ability to move and possibly to speak. And we need to start by looking somewhere in the brain and being able to detect the intention to move or the intention to speak. And in order to do that, there's some questions that we need to answer while we're sitting at our desk and planning or designing a BCI. We have to think a little bit about what types of signals there are available in the brain to record and where in the brain we might want to record those signals from. And then with the answer to those two questions, we choose a particular sensor to record that kind of signal from those particular areas. Once we have that signal in our hands, so to speak, or we have access to that signal, we then need to put that signal into a black box. And that black box is the home of our friends in the field of computational neuroscience. Dr. Ruben, Dan Rubin, is one of those computational neuroscientists. And they, in a lot of ways, have what I think is one of the most fun jobs in the world, which is to understand the language of the nervous system. To understand, for example, how when a single neuron in the brain is firing away and it's increasing its firing rate or decreasing its firing rate or changing the pattern of its firing rate, what does that mean? What is that neuron trying to tell another neuron? And if we can understand that language, and we can relate it in some way, for example, to the intention to move one's hand, the way that we do that, sitting between those two, is math. And I have reduced lots of math to the capital letter A here, which is where a lot of the research is focused. How do we take a complex signal, relate it to a simple and clear output, and allow somebody who is having difficulty or is unable to use their hand to control an external device, again, just by thinking about the movement of their own hand. Before we leave the bench, we want to think a little bit about what we hope that technology will actually be able to do. for somebody who's having difficulty communicating, unable to use their computer, possibly, or a very slow rate of being able to type, if we can speed up that rate of typing, if we can allow for complete control over tablet computers, if we can restore the ability to use the intended speech, that is, somebody attempts to speak, to convert that intended speech into actual computer-generated speech, or any number of other devices or systems that could be controlled by thought alone, if you will, informally. Those would all be, we think, worthy endeavors and part of how we put together a brain-computer interface. I won't go through the rest of those technologies that are on there, but each of those has some potential to be able to be controlled or to become part of a brain-computer interface that would become helpful for somebody with paralysis. So just a quick shout out. I'm going to be telling you about one clinical trial for people with ALS and other forms of paralysis. But if you're not familiar with some of these, I just wanted to put them up on the screen. Each of these has either a few or a lot of different ongoing trials in ALS and in other motor neuron diseases. I'd encourage you to grab any of those as a screenshot or to go to any of those. And I've just put at the bottom there our BrainGate.org website to learn more about this particular trial. So the summary of this trial, in at least illustration form, is that we place what we call an array of electrodes, which is right here. It's a 4x4 millimeter platform of electrodes, and I'll show you one of those in just a moment. We tap it in to a part of the brain called the motor cortex that's important for the control of movement. And then it's connected by some fine wires to a pedestal, which is the fancy name that we give to a plug, that sits on the top of the head, is secured to the top of the head. And then when everything's working the way that we want and expect it to, person with ALS, or perhaps a person with another form of paralysis, thinks about the movement of their own hand. We can decode the brain activity, which is up there on the right, and allow that person to control, for example, a cursor on a computer screen just by thinking about the movement of their own hand. Since we launched this trial back in 2004, there have been 14 participants in the BrainGate research. And what I've listed on the right are other groups that are using the same type of technology, the same type of implanted array, or arrays, plural, placed into the brain for chronic neuroprosthetic research, that is, to develop technologies that would restore communication or mobility. And I list them there in particular because if one of these institutions happens to be near where you live, they would be great institutions to reach out to find out more about the trial. Our BrainGate research, as I'll tell you in a moment, is based both here in Boston and Providence, as well as in Cleveland and at Stanford and Palo Alto in California. Other groups using the same technology for a slightly different version of the same research, still about recovery, in this case from stroke or other forms of paralysis or ALS. And then down at the bottom are other brain implanted or placed on top of the brain technologies, still for recording neural activity for control of an external device. So there's been lots of experience, and roughly 28, 30 or so people worldwide who have had devices placed chronically in the brain specifically to enable control of external devices. I'll hasten to mention that while that number, well, I'll let you decide whether that number of 28, 30 is big or small, but there have been more than 200,000 deep brain stimulators placed much more deeply into the brain, much larger devices, for example, to help people to manage the symptoms of Parkinson's disease. Cochlear implants, another example of brain implanted devices. So the field of placing neurotechnologies in or around the brain has actually been around for quite some time. It's just this particular array of electrodes and other recording devices that are somewhat newer. Our BrainGate Consortium includes sites for the administration of the clinical trial and the clinical research home, which is here at MGH, together with our scientific and clinical colleagues at Brown, at Case Western, at Stanford, and at the Department of Veterans Affairs, that is the VA Medical Center in Providence. And being able to do this research, as I showed in that earlier slide, with all of the intellectual capacity and the different ideas, sometimes competing ideas that get raised at these consortium meetings, which are weekly, really is what allows us, we think, to do the very best research that we can, constantly challenging each other to get better and better at the neural decoding that's central to this research. So the standard clinical trial outline. Participants who we recruit have limited use of their hands due to motor neuron disease, spinal cord injury, stroke, or muscular dystrophy. I will mention that for ALS, we can recruit people who are fairly early on, who have just a little bit of weakness in the hands. And we can also recruit people who have more advanced disease, who have lost the ability to use their hands and possibly also lost the ability to speak. We recruit adults who are at least a year out from their injury or roughly from diagnosis. They do need to be able to communicate, but not necessarily be able to speak. We have recruited people who have a version of locked-in syndrome who can communicate readily, albeit slowly, with their eyes. And as long as that person is able to ask and answer questions, then we can recruit them. And they need to live within about 3 hours of one of our study sites, because once the device is placed, which of course happens in a sterile operating room, the participant returns home and all of the rest of the research for a year or more occurs in that person's living room or wherever they may live. We come to you, so to speak, in order to do this research. And part of that is because we really wanted from the beginning to develop and test this technology, not in the ivory tower, not in the university laboratory, which has conveniences. We can perfectly control it. We can build a Faraday cage. We can block out any electromagnetic noise, but that's not where technologies actually need to work. They need to work in somebody's home and then become more and more mobile from there. And so we've been really privileged to be able to conduct this research, not only with the participant in their home, but quite commonly we get to know the family, we get to know the dog, which I was hearing, I think, a little bit earlier, and really develop this technology and learn how it works where it needs to work most. And as mentioned, those are the sites that we're recruiting at. So one question that was asked really early on, and it was, we had gotten a little bit of experience recording from the motor cortex of people who had spinal cord injury. And we proposed to begin to record from the motor cortex of somebody with ALS. And I'm going to take just a moment to try, which may not work at all. Either Lisa or Dan, I'll let you tell me how I'm doing here. I want to show you the array, which is this thing, which may or may not on Zoom look like much. The most important point is this thing, which I know is tiny. This is the array. I'm going to put up my hand. And Dan, if you want to shout out whether this is even remotely visible.
Good.
That was a good. It is
tiny.
It's tiny. Good. That's the point. I'll try to hold it still, but it's kind of bouncing around on the flexible wires. So that array is what has 100 tiny electrodes on it, each of which is able to record from one or more neurons. And the question that was posed is, in somebody particularly with advanced ALS, there was a sense, based in part on clinical experience, that the motor cortex was injured and that it would not allow us to record. That is, there wouldn't be any information there to record. So I'm going to show, and I think I've made this fairly quiet. Maybe I'm going to turn up the volume for just a moment. And if that sounded like static on an old AM radio, you were hearing it correctly. That is music to the ears of a neurophysiologist. That is the sound of neurons firing away. That is the amplified waveform of neural activity. And each of these, to me at least, very pretty colorful squiggles is an electrode that's recording from a well-discriminated individual neuron in the motor cortex of somebody with advanced ALS. And there's a very scientific name for the amount of neural data that we're able to record. This is called a boatload. We have consistently been able to record lots of neural activity from the participants in our trial, including people with ALS, and allowing them to control external devices by thinking about the movement of their own hand. And I'll show you some examples of that. So good news, not just for this trial, but for any neurorehabilitation or any intervention to slow or reverse the course of ALS. There are neural data, there are neurons in the motor cortex that are continuing to modulate with the intention to move, that are still trying, if you will, to do their job to re-enable movement. In our research, we can harness that activity for the control of an external device. So here, you currently have the perspective of one of the participants in our trial. He was looking at this computer screen. This happened to be somebody with ALS, and he has control over that little white dot. He has no functional use of his hand, but he's thinking about using his own hand in order to move that cursor onto the target. We put the target on the screen, which is right now the red circle. And he's just thinking about moving his hand. And when he gets there, he imagines clicking or squeezing his hand or tapping with his index finger. So that point and click control is really very standard for us now, that even though he's unable to do that with his own hand, he can think about it. He can imagine or intend to move his own hand and in real time point and click. Now that's a video game. It's not all that interesting perhaps by itself, but the other reason I wanted to show this video is just to reinforce what's in the background, which is not our lab and is not the medical center. It's our participant's home. It's his couch, that's his artwork. And we collectively are learning how to use this technology where it needs to work. So with that kind of point and click control, with that kind of speed, as mentioned, one of the hopes is that we can develop technologies that will allow for control of different external devices. And I'm going to come back in just a moment to communication. This video is one that possibly you've seen before. This is a woman who did not have ALS. She had a brainstem stroke, had a version of locked-in syndrome. The stroke that relative to this video had occurred more than 14 years earlier. I thought there was a question there. She did not regain the ability to speak. She didn't have the ability to use her hands, but she was awake and alert, and she could move her head and she could move her eyes. I'll come back to tell you about this plug in a moment, but what she's doing is she's thinking about reaching out to pick up that thermos. And after she was able to position that thermos right in front of her, she's then thinking about turning her wrist to put the straw into her mouth. Now, the next 30 seconds or so are not really focused on neurotechnology. Because of the stroke, she had a limited sip power, so it takes a while for her to be able to get that, what I'll tell you for scientific precision is a cinnamon latte, into her mouth. But what I'll point out is that while she's doing this, up until the time this video was taken, for the prior 14 years, whenever she had wanted to take something to drink, somebody would have not only need to pour that cinnamon latte or that drink into a thermos or a cup, but to also bring that cup next to the headrest and the cup holder that was attached to the headrest of her wheelchair. And I'll just pause for her reaction. And then to put the straw into her mouth so she could take that drink. And here, that was that reaction is not because it's the first time in 14 years that she's had something to drink, but because it was the first time in more than 14 years that she had been able to do so solely of her own volition. She was thinking about bringing that thermos. She brought that straw into her mouth and was able to do that. And she was happy and we were happy. One of the questions returning to cursor control, or even for robotic arm control, is how long does it take for a user to learn how to control the cursor just by thinking about the movement of their own hand? So a gentleman in the upper left-hand corner is David Brigham, one of my former PhD students and currently a neurosurgery fellow. And he wanted to see how quickly we could train that black box that I was referring to before. That is, how quickly could we train a decoder to understand a person's brain activity related to the control of a cursor on a computer screen. There are two videos on the screen at the moment. I'll press play shortly. On the main screen, there's one person, and the upper right is a different person. I'll tell you about him in just a moment. And when I just press play, the black box here knows nothing. That is, the decoder is what we would call not seated or naive, but basically it knows nothing. But what we're doing is we've asked our participants, who again is somebody who's unable to control his hand, no ability to move his hand, to think about moving his own hand. And as he does that, he's moving his own hand in order to move the cursor towards the target. Now, we always know where the target is. That means the computer knows where the target is. We know what the participant's trying to do. And every 3 seconds or so, we can update that decoder. We can update that filter. And now that I've been trying to describe it for the last 40 seconds or so, what has emerged from a naive filter that did not know anything about brain activity is not bad two-dimensional control of the cursor. And this will continue to get better over the next few minutes. I won't play it for the next few minutes, but of being able to say that we'll be able to restore some type of function tomorrow I really mean that within a matter of tens of seconds or minutes, we should be able to provide at least two-dimensional control over a computer cursor. This is a quick anecdote. In the upper right-hand corner was essentially the same video, except that that gentleman had never used any brain-computer interface of any sort before. It was the very first time that he used either BrainGate or any other BCI. We had done this in the version that you saw on the big screen to begin with, and we're trying this for a second time with somebody who had never used a BCI before. We started it, David Brandman was there, a minute went by, the cursor's still not moving anywhere usefully. Another minute goes by, it's still wandering around. You can imagine the scientific team at this point is a little bit dejected that it's not quite working the way that they want it to, at which point our participant turned to us and said, "When should I start?" So we decided that now would be a good time to start. So we reset everything, and sure enough, he was very quickly able to get control again of that cursor. All right, so if point and click control can be rapidly acquired, we're working towards developing communication devices. Here is one type of communication interface. This is an optimized keyboard where the most common letters in the alphabet, in the English alphabet at least, appear right down the middle, which is why you see THE there. And we've asked here a woman with ALS to copy the phrase that's at the top of the screen. And you can get a sense for the speed and accuracy with which she's able to do this. She and others were able to get upwards of 30, 35, 39 correct characters per minute. And that's without using any of the word prediction that, of course, is standard fare on tablet computers or other communication interfaces today. And that at the time was about 10 times faster than the best EEG, that is Scout-based BCI being used by somebody with paralysis. When we saw this, though, this speed of communication, the speed of point and click control, it finally dawned on us, why were we, group of neurologists, neuroscientists, neuroengineers, building communication interfaces? There's actually a whole industry that builds communication interfaces, and it's not us, it's in Silicon Valley. And so we did what many people might do, which is we got onto Amazon Prime and we ordered 2 Google Nexus tablets, and they arrived 48 hours later. And you're looking at 2 people with ALS. The woman on the left has one of these arrays that I was showing you placed in the brain, one of the small plugs or connectors secured to the top of the head, and then one of these medium-sized cables that I will make go away in a few slides, connected to the rest of the neural recording system. She is using a completely unmodified tablet computer with all of its power in order to send a typical email with the standard screen. And she there happens to be sending an email to Paul Nujukian, who's then one of the postdocs, now faculty at Stanford. Gentleman on the right, also like woman on the left, mechanically ventilated, has ALS. He had 2 of these arrays placed in the brain, 2 small connectors, 2 medium-sized plugs. He was just doing a YouTube search for ALS and is again just using that typical app. So getting back to one of those goals of being able to restore communication quickly, that is tomorrow, one of the ways that I mean that is by being able to restore the ability to use the same tablet computer or desktop computer or mobile phone as one was able to use before the onset of disease or injury. We don't want to build a system for assistive technologies. We want to restore the ability to use communication technologies with all of their power. And this was one of the recent demonstrations of progress in that direction. One very, I guess, I claimed that the other slide was Sciency. This is probably the most Sciency slide. I will focus only on the pretty colors that are here that I like to look at least. Really what we're here doing is asking one of our participants, somebody who happened to have spinal cord injury, to speak different phonemes, that is to speak different either vowels or the phonemes that are listed there. And what you may see, without me going into much detail, is that there's somewhat different patterns of neural activity that we can see, each of those little ticks representing an action potential from one neuron. We can see different neural activity, we can hear different neural activity as somebody was speaking each of these phonemes. And without getting into too much detail on the slide, we were able to distinguish amongst these 10 phonemes that were being spoken quite well, with about 84+% accuracy. Now, we'd like to do better than 84% accuracy, and we'd like to be able to do that with more than 10 phonemes. But what's most interesting here is that we were able to do this from the wrong part of the brain. we were recording from the part of the motor cortex that controls the hand, not the part of the brain, more laterally, the motor cortex, that's involved in the generation of speech. So even when we're somewhat distant from what we would reasonably believe to be the location that is richest with information related to speech, we can still do a pretty good job already in decoding at least phonemes or syllables related to speech production, which makes me think, together with the great work being done by others, including Eddie Chang, Sid Cash, Christian Herf, and others, that in the future and in our ongoing research, we're going to be able to decode intended speech, even from somebody who may be losing the ability to speak or has lost the ability to speak due to ALS. Whether we're really able to do that, we'll find out, but that's some of our ongoing research that we're really excited about getting to. Another method for communication is handwriting. Talked about point and click, talked about speech. Just published a few weeks ago, one of our participants who's unable to use his hand thought about handwriting, that is, thought about writing letters. And what you're looking at on the screen are what we might call the neural trajectories, the neural pen ink that is, as somebody is attempting to write each of these letters on a piece of paper. But they're not actually the pen in hand, they are the output of the neural activity that's been brought through the decoder. And each of those greenish squiggles look somewhat like letters. So even though we're able to do that fairly quickly, what we actually do is take the neural activity, even more quickly recognize what letter somebody is attempting to write. And here's an example of a gentleman with cervical spinal cord injury, unable to use his hand, asked a question, and he is handwriting or attempting to handwrite the answer to the question. And you're seeing in real time his ability to answer that question. His ability to do this, getting upwards of 90 characters per minute, real-time decoding. And you're seeing this truly in real time. There will be, if we watch long enough, there will be an error or two in our ability to decode single letters. But we can bring this back through some language models that are now quite common and get upwards of 99% accuracy. It's already 94+% accuracy. Actually, there's a letter missing. There's the R that's missing. If we had been putting this through a language model, that would have been detected and been the full word prefer. So I and the rest of the team are really excited about the speed with which we might be able to re-enable communication by using this type of very natural attempted handwriting decoded into text to appear on a screen, which could, of course, be also brought through a text-to-speech generator. You've been looking at people who have a big plug attached to a little plug. That big plug is not a future medical technology. It needs to be eventually fully implanted, made smaller. And a first step to that is making it wireless, which we've done. So I can now get rid of that big plug. The other thing that I'm now holding in my hand is the wireless transmitter that can be placed just on top of the plug that sits on the head. So much smaller, much more portable, if you will, untethers the user from the rest of the recording system. And that system that was developed by Archer D'Amico and Ming Yin and Dave Borton at Brown, we've been able now to use in our clinical trial as well. So I think this is the last video that I'll show you in just a few more slides. Gentleman who's laying on his right side, this is a fluorescent orangish or red neck pillow. And this blurry thing here is one of these wireless neural transmitters. I'm going to press play and we'll see him controlling that kind of typical here Windows Surface tablet by thinking about the movement of his own hand, and here doing so wirelessly. There'll be a little bit of music in the background, or speech in the background. Music will appear in a moment. So that is Pandora. Typical app. And now put that mini cursor and click.
Give it the thumb. There you go.
So that point and click control with that accuracy wirelessly, I think is another example of our excitement and the progress towards re-enabling control over external devices. You may have heard some other people laughing or giggling in the background. Turns out that was the FDA. And now, when the FDA laughs at your research, that could actually go either way. But they were there with us learning for the first time altogether how somebody might be able to use a wireless neural interface in their own home, part of an experiential learning program for FDA and really kind of real-time learning for all of us, how somebody could use a device like this in their own home. This same device has been very helpful over the past year because caregivers, rather than neurotechnologists, can apply this at home. And we've been able to continue our research even through this COVID period by having caregivers attach this wireless transmitter and allow people to use this BrainGate system while they're home, even without us there. So I'll begin to wrap up here. Very simple goal. This goal does not make any particular reference to any technology, but I think the one that we've been working on is making good progress towards achieving this goal. Ongoing research is to create full intuitive instant, that is within a minute or two, and always available tablet computer control for somebody who's lost the ability to use their own hands, whether that be using a point and click or a swipe or other grasp-like gestures that use for tablet computer, handwriting for rapid communication. Very early days of beginning to decode speech, but being able to hopefully decode speech, a very rapid method of communication, into text, and also control over other communication assistive devices. And I'll point out that every incredible participant in our research, whether they have ALS or another form of paralysis, is helping us to develop and test a system that will help other people with paralysis. And I think that the progress towards these goals continues to be substantial, and I'm really encouraged about not just what we and the BrainGate team have been doing, but where this field of intracortical intracranial brain-computer interfaces is going. And with that, I will just show some of our team and what is clearly a just pre-2020 picture. If there's additional information that either Dan or I or anybody can provide about the ongoing clinical trials, feel free to email us at clinicaltrials@braingate.org. Website is down there as well at braingate.org. Thanks again to everybody at Everything ALS for the opportunity to join you today. And I will unshare my slides and be happy to answer any questions. Thanks.
Well, first off, thank you so much for that wonderful presentation. You can see in the chat, people are just very excited about all this new technology and what this means for the future of ALS and other neurodegenerative diseases as well. I'm going to introduce myself. My name is Sarah. I'm also a co-founder of Everything ALS, along with Lisa and the wonderful other people on my team that are also here tonight. I, along with Zoe, who is another team member, are going to be asking some questions, and anything that's in the chat, if anyone wants to bounce back and forth, Dr. Ruben, also answers any way that you can. So our first question kind of goes from some of the information that you guys provided in the pre-video. Are participants in the trial able to be in other trials, like maybe a medication drug trial, and also participate in the BrainGate trial as well?
Yeah, thanks for the question. The short answer is yes. We have very few exclusions, and there have been people who have been in our trial who have concurrently or just previously been in other trials. Really, the only expectation in terms of a potential challenge in being in two trials at the same time is the time commitment. There's a substantial engagement of using this device. Generally, we visit the person in their home about 2 days a week, could be 3 or more days a week, up to that particular person who's in the trial. And when we're there, we're usually there for 2 or 3 hours. And if being in somebody's home for 2 hours or 3 hours, 2 or 3 days a week is more than what another trial would permit, because that same trial requires the same commitment, then that would probably just be a time conflict. The only medical potential contraindication or conflict would be as if somebody is either for other clinical purposes or for any ALS related reason is taking a powerful immunosuppressant that increases the risk of a skin infection or infection really of any kind. Because we're doing because neurosurgery is part of this, and because there is a device that protrudes through the skin, if we knew that somebody was taking a medicine that increased the risk of skin infection, that would be a reasonable medical contraindication that would suggest that we shouldn't enroll that person into the trial. But other than that, we're happy to chat and think through any other potential trials. And as I said, there have been people that have either previously or concurrently been engaged in other ALS research while working with us.
Wonderful.
Hi, Dr. Hochberg. It's wonderful to see you again. I know we've already met, but I guess I'll introduce myself again. My name is Zoe. I got involved with the Everything ALS community mainly for my father, who was diagnosed in 2017. And ever since, I've just been so heartwarmed by just this amazing community and family that we've developed on here. And I'm grateful to every single one of you on this call for having hope, and to BrainGate for providing that hope for all those ALS patients out there that can't communicate to their families and loved ones. And with that, we'll go on to our second question. Some of our participants want to know and hear your input on how this compares to the current eye gaze technologies and what this can offer that could possibly be an advantage in comparison.
Yeah, thanks, Zoe, and it's great to see you as well. So this technology needs to be better than an eye gaze technology, because if it's not, there's no reason to have a surgery in order to use it. And so when I think, so there's a few things about eye gaze technologies that, at least in my experience, when I've been in the homes of people with ALS, that I've seen, unfortunately, repeatedly. One is that very commonly they lose calibration. They need to be recalibrated so that the location of the eyes can be kind of retaught to the computer, so the computer knows where the eyes are. They can be quite fatiguing. That use of eye gaze technologies for hours on end can, by itself be fatiguing in what is already maybe a condition where there's fatigue at baseline because of the rest of the disease. The eyes themselves are important for communication, for looking at the person with whom you're communicating, and encumbering eye movement for communication, again, takes away from some of the ability to have that connection with a friend or family member or caregiver that you would otherwise be communicating with. In addition, even when we're just with a, I don't know if that's a lowercase j or not, but just in italics, using the BrainGate system for a fairly simple communication task, those same signals are able to control multiple technologies. They could be controlling a tablet computer or the laptop computer or an assistive robotic arm or some other device. We're beginning to do some research with soft robotics for limb mobility. And the ever-presence, and I'm speaking somewhat forward-looking, the reason to develop these technologies is because they should be available 24 hours a day, 7 days a week. They should work whether it's light or it's dark, or you're inside or outside. They should be mobile. They should move with the person, whether that person is in their own home or they're in the car, they're at work, or they're at the beach, wherever that person may be. The technology should move with them, and it should be flexible and intuitive and non-fatiguing. And because we're recording from a part of the brain that pretty much it controls external devices, it normally controlled the hand prior to the onset of disease. It was built, if you will, to control the hand intuitively. And when somebody who's able-bodied thinks about reaching for a coffee cup, they don't really think about reaching for a coffee cup. They just do it. It's that easy, or I don't know if I want to call that subconscious, but it's natural and it's intuitive. And that's what we really want these technologies to be. And for all those reasons, I think that these types of intracortical brain-computer interfaces will be faster, more reliable, more flexible than eye gaze technologies may be. And so that's why we continue to work on them. But it is important that whenever considering any technology, one should say, what is available today? And is this better, or could this be better? And if the answer is no, then it's probably not worth continuing in that branch of research or considering that particular technology. I'm confident that these technologies are going to provide a substantial power and opportunity that the eye gaze technologies, unfortunately, even though right now they do serve an important purpose, that those technologies may not be able to.
Hi, doctor. I have a question as well for you.
Please.
I'm actually a patient with DBS and also with dystonia. And so I wanted to ask, is the math used to decode neuroactivity consistent for every type of neuroactivity, whether it's used for the decoding speech or for decoding hand movement?
So the math that we're using, so each person, I'm going to make a statement that is so obvious I shouldn't even say it out loud. Each person is different. So now that I've said that and everybody recognizes that I should have never even said something that obvious, even though each person is different and each person's neural activity, of course, is going to be different, the goal is to create a mathematical framework, to create a decoding algorithm that is generalizable, meaning that we can apply the same type of math to decode either an attempted reaching movement or perhaps even intended speech or the intended movement of a cursor on a computer screen. So the machine learning, if you will, artificial intelligence, the neural decoding components of all of this, the better they are, the more generalizable they will be. And not only will they be generally applicable from one person to the next, but they should also be applicable or easily switchable from one activity to the next, even when used by the same person.
Thank you.
You bet.
So our next question goes to the 3-hour rule. When you spoke about how close you have to be to a site, could you maybe list again the sites that are available, and is there any exceptions to that 3-hour rule?
So the sites that are currently enrolling are Massachusetts General Hospital in Boston, the Providence VA Medical Center in Providence, Rhode Island, Stanford University in Palo Alto, San Francisco, and also very similar research that's ongoing, although I'm not sure if I'm going with people who have ALS at Case Western Reserve University in Cleveland. So those 4 sites, Boston, Providence, Cleveland, and San Francisco, are all actively recruiting for either this research that I was describing or something similar to it. The 3-hour drive time is intended to know that we can get to our participant within, roughly speaking, half a day or less than half a day, and be able to perform one of these in-person research sessions, and then either return home that night or have one of our research assistants staying in a hotel that evening and then returning to do that, to continue and engage in the research more that day. And also because early on we're doing, as would be true in any device trial, safety checks or safety evaluations once a week for 6 weeks and once a month thereafter. We've so far limited ourselves to the 3-hour drive time. I think it's possible in the future that could expand. That can only really expand with permission from the regulatory agencies, including the institutional review boards and the FDA. So right now we do have a rule, which is the 3-hour drive time. It is possible that it could be extended, but that would have to be a discussion, and we'd have to figure out how logistically we can do what we really want to do, which is if we're going to deploy a system and somebody's going to join us on the research, we want to be sure that we can be there, we can troubleshoot anything that's not working, and we can do the research that's going to really move the field forward towards helping people with ALS.
That's awesome. Thank you.
So the next question is in regards to a technology called the Centroid technology. And if you could comment on that and how a brain implant could compare to that.
Sure. So quick disclosure that you may have seen in the earlier slide. So through Mass General, I have a clinical research, or the hospital has a clinical research support agreement with the company called Synchron that makes the Centroid, as well as with a few other companies that are developing these different types of brain-computer interfaces. And just to say, the reason that we have those relationships is I want to make sure that everything we're learning in the BrainGate trials is available to help any private company that is also trying to develop technology to help people with paralysis. So whatever we have learned over these years that we can share, we want to be able to do that. For the Centroid technology itself, I will generally let the company talk more about the technology than I will, but I will say that as the person who asked and others may know, it's a really novel approach to recording neural activity. The Centroid is placed, as it sounds, by a stent, that is by an intravascular device, generally used to keep a blood vessel open, but in this case being used to kind of be secured to a blood vessel wall, specifically the superior sagittal sinus. It has recording electrodes that are on that. It is a fully implanted system and can record from essentially on top of the brain, recording signals not as refined and information rich as we can with an intracortical device, such as the Utah array that we use in the BrainGate research. But it can record signals that can be obtained from on top of the brain. And I think that there is a paper that was published. I happen to have been a co-author on it, but really done by the researchers in the company and the folks at the University of Melbourne, showing the results from the first 2 participants in that Centroid trial. And I think they were getting some early nice results in combining eye gaze with that, with a click type signal that they could record from that Centroid. So really, I think exciting, novel, interesting technology. Early days of the clinical trial. I suspect they're continuing to learn a lot about how to use it, how to deploy it most effectively. And if that trial becomes available in your area, I'd certainly encourage you to reach out and learn more about it.
That's wonderful. Our next question talks about, how do participants feel during the trial? Do they ever say that they have to encourage a lot of focus or energy? Is there any exhaustion from utilizing the system?
I'm just going to hop in just to let you know it is 7:50.
Thank you. That's Dr. Daniel Ruben, also known as Timekeeper, among many other outstanding skills and insights. Thanks, Dan. Let me answer this question, then I'm going to hand off and then hand off to you. So the question about how hard does somebody have to work? So one of many favorite parts of the trial for me is asking somebody, what are you doing when you're controlling that cursor on the computer screen? And my favorite answer is somewhere between silence and I don't know, I'm just doing it.
Okay.
And that's the answer I want to hear. It's for somebody who's able-bodied. If that person were to describe, if that person was holding a pen and writing on a piece of paper, and were to ask them, how are you doing that? They might be able to make up an answer that says, well, I'm squeezing the pen between my thumb and my index finger, and I'm extending my elbow and a little bit of my wrist in order to draw. But that is a made-up answer. That is not what that person is doing. They're just writing. And when we on the computational neuroscience team are doing our job right in accurately decoding the intended movement, it is effortless, and it is natural, and it is intuitive. Now, when we don't do our job right, which happens, and it happens because this is research, and I should take the opportunity to underscore that this is research with a capital R. It's not yet a clinical product that is available. This is an investigational system. And what we're learning is sometimes we think we have a great idea about how to make the neural decoding even better. We deploy it, we see a cursor moving on a screen or an external device. It seems to be going fairly well. And we ask participant, how's it going? And they say, it's not quite right, or I'm actually having to try harder than I did last week. So can we please go back to the system that we used last week? And that's how we learn, is we get that immediate feedback. And but when everything is working, which is thankfully common, it is not something that requires a lot of effort, and it shouldn't, because our job is to take the neural activity, know what it means in tens of milliseconds, and allow that neural activity, that intended movement, to be turned back into to movement or control of an external device.
That's amazing.
So with that, I want to continue to answer as many questions as I can, but Dan Rubin's going to do a far better job than I will in answering questions, and I have to click and then click to unfortunately join another meeting. But I just want to thank you again, Lisa, Sarah, Zoe, everybody at Everything ALS for the opportunity to join you today to tell you a little bit about our BrainGate research. Daniel will tell you even more. And if there are questions that we don't get a chance to answer, please do reach out to us. And if you happen to be interested in learning more about the trial itself, and even thinking that maybe you'd like to enroll, we have lots more to tell you about the trial, and we'd be happy to provide more information and engage in discussion if you're interested. So again, I just want to thank everybody for the opportunity, and I will hand off to the good Dr. Ruben.
Well, thank you again for your time.
You bet. Thanks. Bye-bye.
Bye, thank you.
Well, I am happy to answer more questions. I'm here all night. So please let me know what I can do, and I'll do my best. He's a tough act to follow, but I've been following his show for a while now, so I got the hang of it.
He's always muted.
Oh, do you want me to?
No, I think here, hold on. I think Zoe somehow got muted. Just a second.
Oh, I see.
Thank you. Sorry. So the next question for you is, how does this pertain to motor function? And is there any applicability for this device to improve motor function for ALS patients, whether that's voluntary motor function or involuntary, like breathing?
That's a great question. So I see that, and I was scanning through the chat, and I think there's a related question. So you might have recalled from one of the first slides, there was a list of sort of near-term and long-term goals about things that we think that this technology is going to be able to do. And one thing that we're very excited about, but is in a much earlier stage of development, is the notion of FES, that's functional electrical stimulation. And the way that FES traditionally works is that rather than these types of electrodes, which are recording electrodes, stimulating electrodes are placed, say, in the peripheral nerves and used to directly stimulate the muscles to reintroduce movement. And so one thing that early on in this research became apparent as a possibility was the idea to connect this type of recording output, so an electrode array in the brain that's recording intended movement, and pair that with one of these FES systems, these functional electrical stimulation systems, and to give an individual an opportunity not just to think about controlling their hand or their fingers to control a computer cursor or robotic arm, but to reanimate their own arm, their own limbs. And so there is research that's ongoing in that domain. So one of the things that Leigh had mentioned was a related but slightly distinct research program going on at Cleveland. And that's exactly what they're doing there, is pairing this technology, the BrainGate recording technology, with an FES system to try and restore mobility, specifically to the arm, using this sort of recording technology. They've had one, I think they recently implanted the combination of the BrainGate electrode and the functional electrical stimulation in their second participant. A video that they published from the first participant shows a gentleman with a spinal cord injury who was able to use his own arm to feed himself for the first time, I think in just shy of a decade. And so we're very hopeful that that research is going to continue to progress alongside this. So as we develop more and more accurate and effective decoders, they're able to develop more and more precise functional electrical stimulation systems, and hopefully those two can be paired together. But that's much earlier on, and again, a slightly different trial, so we wouldn't be recruiting directly for that trial, but there is research going on, and as Leigh said, we work closely with that team, and we keep up to date on all of the great work they're doing for all the reasons you could imagine, thinking about the possibilities that we could use that for our trial participants as well down the road.
Every answer, I'm just even more and more waiting for the next one. I'm so excited about it. I'm so excited. Our next question is asking, are there trials working on both speech and movement technology simultaneously? If a participant is being studied for one thing, are they also being studied for the other?
That's a great question. And I think it's great, and I'm going to use that as an opportunity to both, one, the short answer, yes. So an individual who would enroll in this trial would certainly be able to participate in both of those avenues of research. And then the more long-winded answer just gives me an opportunity to talk a little bit about what is it like as a participant in this trial? What does it mean to be participating in this trial? Because I think, for the sake of time, Leigh didn't dive into the details of that, but I think it's helpful to understand and give us a perspective on how this research is conducted. So one of the big goals of this work, which Leigh did talk about, is the idea that this is a novel technology, and we've got teams of engineers who are working on making it work faster and more precisely. But it's also, it's got a very clear purpose, and that's to restore communication to people with ALS. This is a device that's meant to help people, and our engineers can do math very well, but they're not the individuals who are affected by this disease, and they don't necessarily know what does anyone need on any given day? What's the best way to make this work for patients with ALS? And that's what the clinical research side is all about. So when we're doing these research sessions, so somebody joins the trial, they have, oh, sorry, that's, someone joins the trial, they have the device placed, and we'll turn that off so it stops going off, wonderful. And then they go home. And then our team comes to their home, usually twice a week, to run research sessions. Now, early on those research sessions, for the first couple of weeks, few months, they're somewhat pre-specified because there's certain things we want to make sure that everyone's able to do well, 2D cursor control, control of a tablet computer. But after that, we slowly start to think more and more, well, what do you want to do? How do you envision this device helping you in your life? What are the things that you need this to do and don't need this to do? You know, if we were to give you the ability to control a 3D drone, is that something that's of any interest to you? And say, no, I don't want to drive a drone. And meanwhile, we've had participants who say, are you kidding me? Give me a drone today. What's taking so long? I need to fly a drone with this. Other people say, I want to be able to have more control over my home environment. You know, to be able to turn on and off my own lights, to be able to open and close doors. Other participants have wanted to compose music and say, is there a way that you can let me control a piano keyboard rather than a computer keyboard? And so in that regard, the research sessions end up being, you know, as much us learning how to improve the devices as learning what this device should be doing for our participants. So in that regard, we're doing speech studies now. Anyone who were to enroll in the trial right now would be doing work on movement, on 2D cursor control, and typing. And because one of our priorities is speech, we'd want them to be doing speech research as well. If that was the bigger priority for them, we would spend more time doing that. If they said, this is, you know, of less interest to me, and I'd much rather have more fast solid control over a computer, you know, I'm still, we've had people enrolled in the trial who say, well, this is all well and good, but what really I need is more than just 2D cursor control. I need additional degrees of freedom to control the computer the way that I want to. So one example, one of our trial participants was a voracious reader, and he found that using this device was much less fatiguing and much easier than his current head tracker system. He said, this is great, but what's really hard to do is to scroll pages, because you can imagine you have to go over, you have to sort of click and hold to scroll down through many pages. Can you give me page up and page down? Just find some other intended movement to map to that. And we said, sure, we can do that. And so in essence added, if you want a scroll wheel, an additional degree of freedom to his cursor control. Now he can read his Kindle reader that much easier. So listening to our participants is a big part of it. And that was, like I said, a very long-winded answer to the short answer, which is yes. Participants would certainly be able to do both lines of research.
That's wonderful. And I love that you're doing a very personalized approach, because it is really important to look at each patient's lifestyle instead of just generalizing what everyone needs. So that's a really great approach. The next question that we got is people are wondering whether if they were to move to be within that 3-hour range, how would they know that they would be accepted into the trial before they decided to make that move?
That is, boy, that is a very common and I don't want to say ethically, that's a tough question to answer, particularly without knowing more about the individual and a lot of their details. The short answer is, and this is just the honest truth, the short answer is we discourage folks from moving, upending their life, moving across the country to join the trial. There's a lot of uncertainties that go into the enrollment process. I think what makes a lot of sense, if someone does feel very strongly, would be to reach out to us and start a one-on-one conversation. Again, because there are any number of things that we haven't talked about that go into enrolling in the trial that again would impact someone's eligibility, and we can't, for both regulatory and ethical reasons, say upfront that someone is enrolled if they don't meet the inclusion criteria. But if they move, then they meet the inclusion criteria, because it's sort of a paradox. But if someone wants to discuss a particular situation more, I think it makes sense just to reach out to us. The email is the easiest way, because that way we can set up a time either to do a more detailed one-on-one conversation, or we can have a conversation via email.
You just mentioned that the focus is a lot on speech right now. And so one of the questions was, is there current research being studied on how to develop full words instead of just letter by letter mapping of the brain?
Yeah, absolutely. So there are multiple parallel lines of research going on. So the letter by letter that you saw some videos of, that was, although individual letters were coming up, that wasn't speech, that was intended handwriting. So that was someone who was thinking about writing like with a pen or a pencil in their hand. The other work that Leigh showed briefly was decoding phonemes, which are the sort of letter clusters that make up the individual sounds that we string together to make words. You can think of phonemes sort of as syllables, basically. It's sort of what the linguists refer to when they talk about syllables. Your question, what about whole words? Yeah, so that's definitely the goal. So phonemes are all well and good, and one of the main points of that research that demonstrated decoding phonemes wasn't so much that was the goal, to have someone think about the individual sounds of a word and then have our computer string it together, because that's not a natural way to talk, but mainly to demonstrate that information existed in the part of the cortex that we were recording from. So there's the fundamental neuroscientific question that we had to address before we could even get to the question of decoding speech, is whether or not that information is even accessible in the parts of cortex that we record from. So we traditionally place these arrays in motor cortex, as I'm sure you've all seen in other talks, and has got a very topographic organization. And so different parts of the motor cortex, which is the part of the brain that controls movement, are specific for different parts of the body moving. And for the 17 years that we've been doing this, we always place our arrays in and around the part of motor cortex that controls the hand, because that was where our original goal was, to restore the function that the hand has. And the hand has so many degrees of freedom, we said, well, we'll be able to get a lot of control over a lot of different things if we can accurately map all the things that the hand can do. But what we found in doing that early research is that although when our participants intended to move their hand, we got lots of high quality, easily discriminable signals, if we asked them to do other things, move their feet, move the hand on the other side of their body, we were still getting signals that were usable, which actually led us to question this topographic dogma that only a single part of the body is mapped to a single part of the brain. And in fact, we saw in that research that you could even decode the movements of the mouth by recording from the part of the brain that's traditionally ascribed to being in charge of the hand. And that's what that research showed. But in order to make this a usable device, a usable tool for decoding speech, we would need to be able to decode entire words. And that's really what we're working on right now, is doing exactly that, trying to piece together specific words. It's likely that the way that this is going to progress is that we're going to start with a limited vocabulary, a few dozen, maybe a few hundred words that we can reliably discriminate, give someone the ability to control that small library to begin with, then with the ability to spell out less commonly spoken words letter by letter, and then over time expand that to capture as much of speech as we can.
That's super exciting. So the next question is kind of fun. Some participants are wondering what you're thinking about the far future for this technology, and what sort of capabilities might come from a technology like this in the distant future.
That's a great question. I mean, this is the sort of thing that we think about all the time. Once we have these, these goals down, where do we go next? And there's a lot of ways to go with this. So in the past, when we first started doing this research, we implanted a single array, and then around 10 years ago, we got permission from our regulatory bodies, the FDA and the IRB, to place 2 arrays, for more neurons, gather more data. And more recently, technology has been developed where we can actually place 4 arrays using only 2 pedestals. So now there's 2 pedestals, 2 arrays per pedestal. So we're able to gather data from increasing the number of neurons, which allows us to spread the arrays out gather more and more information. So our hope, once we start having these 2 or 4 array placements, is that we're going to be able to gather enough data that we can start decoding really complex intended movements with more and more facility. So there's less computer power necessary to decode not just 2D movement, but 3D movement. So controlling robotic devices. You saw one example of a single robotic device, but controlling multiple robotic devices, giving people control over their environment. So controlling things like motorized wheelchair, other components of a smart home, if you will. Another big effort that we see going forward is making everything smaller, more compact. So a lot of the videos you saw used 1st and 2nd generation technology. Those large gray plugs have been largely replaced by those small transmitters. Our hope in the not too distant future is actually to do away with the external transmitter altogether and have a fully implanted device, something that looks kind of like a pacemaker, a cardiac pacemaker, where everything's under the skin and there's nothing sticking out. That obviates any risk of infection and makes it that much easier for the participants and one day the patients. The other thing that you didn't see as much of, but is a component of the current system, is the rack of computers that actually do the decoding. So one question that I saw early on in the chat, but I guess I can address it now because it sort of gets to this question, is the computing power that's used to actually do the decoding. So one question was about the bandwidth of the transmitters and whether or not it's possible to transmit less data so that it can be faster. And as it turns out, the big bottleneck in processing isn't at the level of the transmitter, because the transmitter just basically is transmitting broadband signals without much pre-processing. Most of it happens on the rack of computers that sits in the corner of the room in our participants' homes. So if anyone remembers, sort of 1980s looking stereo systems, that's kind of what the computer rack looks like right now. So the device itself is very small, just sort of this tiny little thing peeking through the surface of the skin. And then that transmits to this rack of computers that is decoding the neural signals. And there's this large computer that's, turning it at warp speed for each of the 2 arrays. But our goal is to miniaturize that whole thing into a tiny compact thing, the size of like one of those small desktop PCs that can be externally powered and ideally just sit, for example, behind someone on a motorized wheelchair. So they don't even need to be at home. They can take this on the go. You've got a wireless transmitter. You've got the decoding computer wherever you go. And you're free. And then there's, I could go on and on and on about all the things that we'd love to do with it, but those are sort of the 2 big things: are faster, more precise, high dimensional decoding, and with improved technology, more portability, more speed.
That perfectly takes us into our last question. We want to make sure we respect your time. Our very last question is kind of how participants have to maintain this at home. So do they have any required technology? What is the self-care, as well as is there any restrictions to what they can and cannot do, i.e. shower, go swimming, whatever the case may be?
That's a great question. And something we should have tried to address and talk. So the home care is actually pretty easy. So the big thing that we want to make sure to prevent is infection. Right, so this is an implanted device, and so infection is always the concern. We're happy to say, and I'll knock on my desk right now, which is made of wood, but it's close enough, that with the protocols that we put in place, we've never had a serious infection. In our 14 participants in 70 years of doing this, there's never been anyone who's required more than an oral antibiotic for a little bit of skin irritation, but no one's ever had to have a device explanted because of an intracranial infection. No one's ever gotten meningitis or a bone infection or anything like that. And these are complications that have come up with other implanted devices. Leigh mentioned the deep brain stimulators that have been used for treating Parkinson's and other movement disorders. Of course, there's been hundreds of thousands of those implanted, as he said. But part of the reason why we think we've been successful in preventing an infection is we have a fairly rigorous is not the right word, but we have a well thought out infection prevention protocol. And the way that works is we ask our participants to have a caregiver, either a family member or someone else who helps in their care, clean around the pedestal with a chlorhexidine swab roughly every other day. Now, when we're there doing research sessions, we'll be there and we'll do it during that day if we're coming for a research session. But if it's going to be 2 or 3 days before we're back for another research session, we ask a caregiver to do that. The whole process takes less than 5 minutes. We supply our participants with a big box of these sclerostin wands, so that they've got all the supplies they need, and we train whoever it is that'd be doing it on how to do it in a safe and easy way. But it basically comes down to just moving the hair to the side a little bit and cleaning around the base of the pedestal, making sure that it's nice and clean, there's no debris around it, and the skin looks good. When the device is not in use, the transmitter can come off, and there's a small brown cap that goes on it. If you've got hair, it sort of sits underneath the head. You don't even see it there. And with that on, you can shower, you can swim, you can do just about anything. You can have your hair cut in any way you like. In the past, we've asked folks not to have their hair professionally dyed, just because we don't necessarily know what chemicals individual salons might use. But past that, we've had folks who do swimming at the Y, and that's fine, and you can take a shower. And when the device is not in use, there's no risk about water or anything. Obviously, when you're using the device, we'd ask that you're not go in the shower with the electrical transmitter on your head. There's no risk to you as an individual. It's a one-way stream, but you might break the device, and we'd have to replace just the external component, that is, and we'd have to replace that, and that's expensive.
Okay. Well, thank you for that. That cleared up a lot of last-minute questions. I want to thank you so much for your time. This has been great. I know we have a bunch of more questions left, but out of respect, we will be sending you through them. I sent them to Lisa, so she will be able to forward it on, and anything will be sent out, but we understand if you're too busy. So
we found some early biomarker with the study we've done. We've got about 514 participants. Our goal is to get 1,000. So we are accepted to speak at the Interspeech Conference next month. So we're very excited about it, where we'll announce the first results. So
well done.
And yeah, some good developments happening, and we just need all of us to work on this, because this is something that we can actually change the way the clinical trials are done, because these are the biomarkers that could be augmented along with ALS-FRS scores in the clinical trials. So that's why we hosted a roundtable conference with it's called alsroundtable.com. If you go to that website, you will see about 30 pharma companies attended, and we talked about our project, our digital biomarker, to be included in the clinical trial. So we are pushing it from every angle, including the FDA angle. So we just need all of us to participate. So this is not going to happen without all of us coming together. We would love to get your help to recruit healthy volunteers as controls, and family members, and also people with ALS, PLS. So it's really open for everybody. So yes, any help, any recruiting you can do, that would be fantastic.
Yeah, you pretty much just have to be 18 and older, right? And right now, living in the US.
And US,
Yep.
yeah.
And I can actually say it takes about 10 minutes. It is not, some people may take a little longer if they're talking slower, but if you're a fast talker, you could probably get it done even faster. So it does not take a ton of time.
And also wanted to add, like, a couple of the people have said that their speech is improved because they're speaking to the avatar. So we're actually starting off another research called Speaking Out Loud. So we are getting material from Reader's Digest and
National
Geographic, who are donating their material for a study where you will be able to read out stories loudly and see if that will actually improve the speech. And we're measuring that, and also you'll have a dashboard. So the dashboard is getting released. All of the data that you record will be yours, so you will be able to see it. Actually, one of the person who's participating, he had a very slurry speech, and he started seeing it get better. So that's what inspired us to do this, kick this off, and saying, what if we do 2 to 3 times a week and give stories to speak out loud, and let's go test this. So we're actually doing that project next, which will be coming out soon.